Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Stand Medical Notes. Uh, in the previous video of cardiac arrest part 1, we have discussed about the definition, pathophysiology, epidemiology, etiology, basic life support, advanced life support. We have discussed in detail. Okay, in this second part of cardiac arrest, we will discuss about post cardiac arrest care. So a victim of cardiac arrest who is gaining ROSC, that is nothing but return of spontaneous circulation. So what to do, and what are the signs of ROSC, and how do we prognosticate? How do we prognosticate that patient? Nothing but what will be the outcome of the patient? So he has gained ROSC, but what will be the outcome of the patient? We will discuss in this video of part 2. So let's begin with the name of Allah. So now we have performed BLS, ALS, and we are performing that. Now suddenly we have got ROSC in the patient. Signs of return of spontaneous circulation. We have got those signs. What are those signs? Palpable pulse, or the most important sign is rising endotracheal carbon dioxide more than 40 mmHg, or sudden BP rise. So pulse, BP you are now able to feel, okay. Or in respiration, endotracheal tube you have inserted, that you are having more than 40 mmHg of carbon dioxide, then that represents the sign of ROSC. So what you will do after that, we will provide post cardiac arrest care. Okay, that's very important because mortality of patient is high if it is not good post cardiac arrest care. So what and all we need to remember in that post cardiac arrest care, so we will understand by this diagram. Very good table. So airway you have given, maintain the saturation between 94 to 96% SpO2, and maintain normocapnia, no permissive hypercapnia like in ARDS. Okay, maintain normocapnia less than, meaning carbon dioxide levels in the blood should be less than 45 mm of Hg. Okay, 40 to 45 mm of Hg. So that is about airway and breathing. Now important things in other things are circulation and coronary reperfusion, because coronary artery syndrome is the most common cause of cardiac resuscitation. So simultaneously when you are giving ALS, you are performing ECG and monitoring also. So at that time if you see some coronary event, you will reverse that. So in hemodynamics, hemodynamic instability is common in this patient. That's why it's very important to maintain SBP of 90 mmHg and mean arterial pressure of, this is very important, because BP can be normal 100 mmHg, but mean arterial pressure will be less than 65 mmHg. This is not, that is detrimental actually. So mean arterial arterial pressure should be more than 65 mmHg. And to do that, you can use vasopressors may be required, like noradrenaline, which is the first choice, and fluids with vasopressor may be required, and in some cases dobutamine also. So second thing is coronary reperfusion by PCI. So acute coronary syndrome is a common cause of cardiac arrest. ST elevation or new LBBB, so urgent coronary angiography and PCI should be done regardless of the consciousness of the patient. Consider catheterization even without ST elevation if high suspicion of cardiac disease. So these we should remember in C. So A, B, C, D, E, no, airway, breathing, circulation, disability is nothing but care of the brain, and exposure is nothing but temperature. Okay, so we should remember these things. Okay, now targeted temperature management. What is the purpose of that? So this is also known as therapeutic hypothermia. I have discussed just now. No, improves neurological prognosis by reducing metabolic rate and reperfusion injury. What is the indication for this? All the comatose patient whose GCS is less than 8 or unresponsive post ROSC, return of spontaneous circulation. So spirit, there is ROSC, but there is no that consciousness is still less than GCS is still less than 8. Okay. Applies regardless of initial rhythm, whether the patient had shockable or non-shockable rhythm, that doesn't matter. If the patient is comatose, then you should give targeted temperature management. Target and duration. So duration provided for 24 hours and the target is 32 to 36 degrees centigrade. Fever management important. Hypothermia of more than 37 degrees Celsius worsens neurological outcomes. That's why treat aggressively with antipyretics and active cooling measures. Now after that, the patient has come out, so he has ROSC. Now you will prognostify the neurological, you will do a neurological prognostication in this patient. So how will be the outcome, how will be the prognosis in this patient? This is very important, very very important. Okay, so for that, what should be the time? Okay, that is important. And what should be the approach, what should be the time to for neurological prognostication? What is that neurological in simple ways? So you have given CPR, you have there is ROSC and patient is may or may not have consciousness. At that time we are calculating the prognosis of the patient post cardiac arrest care, in the post cardiac arrest care. So if the prognosis is bad, that will be in this approach we will know. If the prognosis is good, that will also we will know. Okay, so we will use a systematic multimodal strategy for that, and differ this neurological prognostication, not prognostication, my tongue twist. Okay, so differ this neurological prognostication for 72 hours after normothermia to allow sedative clearance and recovery. So this will hinder to prognostic this is a hindrance. So that's why in 3 days, approximately 72 hours, the sedatives will be cleared off. So after that clearance, meaning after in 3 to 5 days approximately, we will perform this neurological prognostication of the patient post cardiac arrest. Very important. Okay, so this is a chart from Oxford which shows how to perform neurological prognostication in patient post cardiac arrest care. See here, very important, the time is also there, the approach is also there. So during day 1, 24 to 42 hours, you will perform a CT scan. Okay, this is important, CT scan. So diffuse axonal injury or something like that, that is a very bad sign which you see, or some hemorrhage if it is there, some stroke if it is there, you will know that in CT scan. And patient can have status myoclonus. What is status myoclonus? Generalized tonic-clonic seizures for more than 30 minutes, that is status myoclonus. If the patient has during for less than 48 hours of post cardiac arrest care, that is a bad sign, that is a has that does not have a good outcome. Okay, so in this these two will in the first two days, these two tools, you can say these two tools, CT scan and having seizures, will know us know us the outcome of the patient. Okay, so at the time what you will do, patient has just ROSC, okay, from cardiac arrest, control temperature for comatose patient, rewarming is done to maintain temperature between 30 to 36 degrees centigrade, that is also there. Now in after 72 hours, more than 72 hours, nothing but 3 to 5 days, 3 to 5 days, what you are doing now? So what and all your tools you are using for prognostication of the patient? So remember, I will just one is clinical tools, we will know that clinical tools. Second is radiological tool like CT and MRI. Okay, third is electrophysiological studies, electro EPS. What is that? In EPS, EEG, electroencephalography, and somatosensory evoked potentials, somatosensory SSEP, evoked potential. Fourth one is markers, biomarkers. So these four we are going to use, these 4 tools we are going to use to prognosticate a patient post cardiac arrest care. Okay, let us break down step by step. So you will do MRI in 3rd day, you will perform electroencephalography and this one, somatosensory evoked potential, and this is biomarker NSE. What is that? Neuron specific enolase. So if it is raised, that means there is the brain injury is very much, it signifies brain injury. Okay, NSE, neuron specific enolase. So these 4 things we are using after 72 hours. And clinically, what we will see? Clinically, we will see pupillary reflex, corneal reflex. Okay, and these 2 things are important clinically, and this GCS we will see. Okay, GCS we will see. This is clinical, and this is biomarker plus electrophysiological study plus radiological investigation. By this we are prognosticating the patient. Exclude the confounders, particularly residual sedation. Confounders are nothing but the sedatives which are given during intubation. So if they are there, that they become a hindrance to prognostication. So you should exclude this. That's why this is important that you prognosticate after 3 days, 3 to 5 days. In these after 3 days you should prognosticate the patient after 72 hours actually. So 2 things, a CT scan and seizures will give clue less than 48 hours. After 3 hours, these are the things. Patient is unconscious and EMV. M is 1 to 2. Okay, at more than means at 3 days after ROSC. If this is the state, the patient is still unconscious and the score of M is just 1 to 2, then next what you are doing, you should see the pupillary and corneal reflexes, and along with that you should see N20 N20 wave in the somatosensory evoked potential. What is N20? N20 is nothing but a dip, negative deep wave which is seen in somatosensory evoked. What is this somatosensory evoked potential? Basically, if this is nerve, okay, you give a stimulus here, okay, and you will record the response from that nerve. This is nothing but somatosensory evoked potential. You give a stimulus and record the response. So N20 is nothing but at 20 millisecond. At 20 millisecond, if the response is not there, at 20 millisecond of this stimulation of that nerve, usually the median nerve is the most common peripheral nerve which is used for this, and this is not only done for peripheral nerves, this is also done for brain and spinal cord also. Okay, so if this is not there, bilaterally absent N20 SSEP or no pupillary corneal reflexes, one or both. So if one among these also present, if it is yes, one of these is present, then poor outcome very likely, very much poor outcome. Okay, nothing is there, SSCP N20 bilateral absent, this is not there, and reflexes are also not absent, then wait for at least 24 hours. After 24 hours, you see whether there was a history of myoclonus less than 2 days after ROSC. See the biomarkers whether they are high. See on EEG unreactive burst suppression or status epilepticus on ECG, and on CT and MRI diffuse anoxic injury on brain in CT and MRI. So if 2 or more of these are present, seizures less than 48 hours, high neuron specific enolase, or EEG has status epilepticus form or unreactive burst suppression waves are there, or diffuse anoxic injury are there in CT and MRI, 2 or more of these are present, then that represent a poor outcome. If yes, then it is poor outcome likely. No, then indeterminate outcome, observe and reevaluate the patient. This is a multi-modal prognostication which is used to know the prognosis of the patient post cardiac arrest care. At 24, more than 12 after ROSC in patient not treated at target temperatures. Okay, so basically, more clearly we will know this thing in this box very easily. This is an easy box for prognostication. Okay, see here, easy box. That is a detailed chart. Modality predictors. That is not modality, actually, is mortality predictors for poor outcome at 3 to 5 days. Less than 48 hours, either CT or seizures. Okay. Clinical signs, poor predictors, bilateral absence of pupillary reflex to light, low false positive rate, bilateral absence of corneal reflex, absent or extensor motor response to pain, absent response to pain or extensor motor response to pain. Okay. Status myoclonus, especially if less than 48 hours post ROSC. So these are the clinical signs, 4 clinical signs which indicate poor outcome. Pupillary reflex, corneal reflex, muscular reflex, extensor motor response, and status myoclonus, seizures. Electrophysiological study, bilateral absence of N20 component on somatosensory evoked potential. Okay. Unreactive burst suppression or status epilepticus on a continuous EEG. So this in imaging, diffuse anoxic injury on CT, MRI, sulcal effacement, loss of gray white matter differentiation, all these things. Biomarkers, high and sustained or increasing levels. So that means you need to measure, repeated measurements are required. Neuron specific enolase and S100B proteins. So these are the biomarkers. If they are increasing or sustained levels are there, then that indicates a poor outcome. So these are the tools. These are the clinical tools. 4 things. In electrophysiological studies, 2 things. Imaging and biomarkers. That's about prognostication. So we have learned about a patient coming out of cardiac arrest, but what about you are resuscitating the patient and patient is not having ROSC? So till what time you will do? Till what time you are going to do that CPR? So that is important. So termination of resuscitation is also important. When to terminate the resuscitation? So what is the criteria? Adult out of hospital TOR criteria is arrest is not witnessed by the emergency medical services. There is no ROSC, no shocks delivered, no bystander CPR. So these are the conditions for adult out of hospital TOR criteria. And in hospital, do the CPR for 20 to 30 minutes. If it is unsuccessful, consider termination if reversible causes are excluded. If there are no reversible causes and you have done half an hour of CPR, then terminate it after half an hour. So half an hour is in hospital setting. For out hospital setting, these are 4 criteria to be fulfilled. Now, what is the prevention now? How to prevent this cardiac arrest? How to prevent this cardiac arrest? So prevention can be primary or secondary. Before the arrest, attack of arrest, or a patient who has who has just now come out of arrest. So how do you prevent, and what should be the long-term management? So prevention of sudden cardiac death. Most sudden cardiac deaths occur in individuals with preserved ventricular function who would not qualify for a primary prevention ICD. Preserved is nothing but HPEF, ejection fraction, HPF, who would not qualify for primary prevention. In those individuals, most SCDs occur. Okay. Most SCDs occur in individuals with preserved ventricular function who would not qualify for a primary prevention ICD. So how do you prevent? Prevention focuses on 3 things, remember. Number 1 is risk factor modification. Number 2 is medical therapy. And last is implantable cardioverter defibrillator. We will see the indications. We have learned these indications for ICD before also. So just what are the risk factor modification? Lifestyle adherence. Avoid smoking. Healthy weight loss in obese patients. Exercise. How much exercise? 120 minutes per week. This is the recommendation. 120 minutes per week. Maintain a BMI of 20 to 25. Okay. And quit smoking. Treatment of conditions like hypertension. Less than 130 should be the goal. 130 by 90 should be the goal. In diabetes patients, same, less than 130 by 90. And if CKD is there, then the goal is less than 120 systolic. Okay, systolic BP. So risk factor modification, that's the one thing. Medical therapy, so GDMT should be given. GDMT, optimal GDMT, you can say optimal GDMT. What is GDMT? 4 drugs you remember in the previous: beta blockers, AC inhibitors, okay, aldosterone antagonist, and SGLT2 inhibitors. These are the 4 drugs. Okay, they have demonstrated efficacy in reducing SCD risk in high risk patient post MI, heart failure, long QT syndrome. Okay, one more here is not mentioned: SGLT2 inhibitors, 2I. Okay, next comes is the implantable cardioverter defibrillator. So this can be used as primary or secondary prevention. We will see that. What are the indications for that? Just we will see. Just we will have a view on that. So the ICD is the treatment of choice for many SCA survivors and high risk patients, significantly improving long term outcomes. So prevention can be primary or secondary. Secondary prevention, so survivor of cardiac arrest due to VF or hemodynamically unstable VT after excluding the reversible causes, class 1 level A recommendation, or patient with structural heart disease with spontaneous sustained VT. Okay, structural heart disease with spontaneous sustained VT. Sustained is recommended more than 30 seconds. Okay, in these two types of patients, so one who had sustained VT, maybe stable or unstable, more than 30 seconds, they should also have this ICD. Primary prevention in ischemic cardiomyopathy. So for example, patients with angina or coronary artery syndrome, prior MI more than 40 days. Ejection fraction should be less than 35%, and patient should be symptomatic with NYHA class 2 to 3 on optimal GDMT. These are the conditions, remember. Okay, so in these patients should receive ICD. Non-ischemic dilated cardiomyopathy, same, DCM. LVF should be less than 35% and patient should be symptomatic on optimal GDMT. Again, GDMT. Maybe ischemic or non-ischemic cardiomyopathy. Other high-risk conditions include hypertrophic cardiomyopathy, arrhythmogenic right ventricular hypertrophy, Brugada syndrome, long QT syndrome, okay, catecholamine provoked ventricular tachycardia, CPVT. So this is class 2 recommendation actually in this condition. So class 1 are these things. Okay. So ICD we have discussed in previous videos. You can go and watch that ICD. So where it is not indicated, okay, clinical scenario: incessant ventricular tachycardia or ventricular fibrillation. Incessant, persistent arrhythmia not amenable to ICD therapy, means the arrhythmia is not resolving only. Okay, so you can't that's there, it is not indicated. Poor prognosis, expected survival of the patient is less than 1 year. This is very important. So if the expected survival of the patient is less than 1 year, their ICD is not indicated because benefit is not, there is no meaningful benefit. Ventricular tachyarrhythmias due to completely reversible causes. Okay. Treat the underlying cause like electrolyte imbalance, drug toxicity, so that ventricular tachycardia will reverse. So just see here, we have just now we have learned this one. Here, sustainable ventricular tachycardia, spontaneous sustainable ventricular tachycardia with structural heart disease. So they should have, but ventricular tachyarrhythmias due to reversible causes, they should not have ICDs. Okay, that differentiation should be done. And this, in this class 1 recommendation is there, but the expected survival should be more than 1 year. If it is less than 1 year, then it is there is no benefit. Now some points, we have completed almost the topic of sudden characteristic in detail, SCA. Okay, differences between pediatric cardiac arrest and adult cardiac arrest. Common cause in adults are cardiac, in pediatric it is respiratory. Remember, compression ventilation ratio is 30:2 for one rescuer, 15:2 for two rescuers. Okay, 52. It is same in case of pediatric. Depth of compression should be more than or equal to 5 cm. Here it is 1/3 of the chest depth, approximately 4 cm in infant and 5 cm in child. 4 cm, or you can remember like this, 1/3 of the chest depth. 1/3 of the chest depth. Okay. One rescuer 30:2, two rescuer 15:2. Shock dose biphasic 120 to 200 joules. Patients remember the dose 4 joules per kg. 4 joules per kg. Drugs, epinephrine and amiodarone you use. Epinephrine 1 mg, amiodarone first dose 300 mg bolus, second dose you can give 150 mg. Pediatric epinephrine you will give, the dose is 0.01 mg per kg. Okay, and shock is 4 joule per kg. 0. Okay, just remember that thing. So special circumstances, for example like in pregnancy, you should keep in mind, so there can be left uterine displacement during CPR. Left uterine displacement during CPR, this is important in patients who have cardiac arrest in pregnancy. In patients with hypothermia, prolonged resuscitation until core temperature is more than 30 degrees centigrade. So in patients cardiac arrest due to hypothermia, prolonged resuscitation can be required until the patient has core body temperature of more than 30 degrees centigrade. Toxicology, you need to do antidotal therapy. Anaphylaxis, epinephrine is the priority. Drowning patients, focus on oxygenation before compressions. This is important. In drowning patient, focus on oxygenation before compressions. So that's all about cardiac arrest. Thank you for your listening. We'll meet in the next video.